My name is Robert Martin. I am a professor of surgery at the University of Louisville School of Medicine. I'm the division director of surgical oncology. The first and foremost where ultrasound is essential in management of pretty much anyone with upper gastrointestinal malignancies, esophageal, gastric, pancreas, bile duct, and liver, is predominantly in staging. Ultrasound is helpful to ensure that a patient truly is a localized disease and not metastatic disease. It's very quick, it's inexpensive, and it doesn't hurt the patient, and it doesn't actually make the procedure that much longer. The second example is predominantly in two areas where the cross-sectional imaging has its underlying limitations, and that's in a hilar or perihilar cholangiocarcinoma, and then in a pancreatic head tumor, most commonly within the uncinate process. In both of those areas, because of the multiple other vital structures that are around, there's a lot of volume averaging that occurs with a CT scan or MRI. And there are times where potentially we think something is resectable, or we think something is marginally resectable, that when we do actually true intraoperative ultrasound and high quality ultrasound, we can see that that disease is either more advanced or more extensive locally than we saw, and thus we don't need to try and do a very extensive dissection and then find that out 2 hours later, because then we've not helped the patient. Or we find that that is actually not as extensively advanced, and we do believe that that patient can undergo surgical resection. So I find it's integral both at the initiation of the surgical management of patients with perihilar or biliary bifurcation sort of cholangiocarcinomas. Utilizing intraoperative ultrasound for any of my cases is now, just as important as, suture or any kind of dissecting device. It's a additional surgical instrument that I use that I think is vitally important. So I've been predominantly focused in utilizing the BK ultrasound for now almost 9 years. And the main focus that I started to use BK ultrasound was it was really the only ultrasound company that wanted to focus on surgical unmet needs. There continues to be innovative advancements that I've seen BK do, whether it be both in their laparoscopic probe, being one of the first probes that actually allowed us to have four-way manipulation as opposed to just up and down. Doesn't sound like a lot, but when you're working on someone with a BMI of 40 and you're working 2 feet away from you and your port is off by 3 centimeters, and just the ability to do 90 degrees, say, to the left, can make your life a whole lot easier and reduce your frustration in the operating room. And then also, moving forward, obviously with dual imaging probes, biplane probe is a huge aspect I do now. It's majority of all my pancreatic ablations and liver ablations are now utilized using a biplane probe. At least being able to image in 2-dimension real time is huge. It's huge for our accuracy, it's huge for our needle placement, and I think helps with patient safety and efficacy when you're using any type of ablative therapy. So I've always been impressed with BK's additional movement of continuing to look at advancements and how it can answer unmet needs within the surgical community and not just be focused in the far larger market, that being just cardiac imaging. It's nice to have a device company that kind of wants to learn what we frustrate with or what are our challenges, and then work with that group of surgeons to identify what are ways that we can make it better, and what's on the horizon that can make our jobs easier intraoperatively. There are dedicated CPT codes where I actually get RVUs by dictating that I did a routine or diagnostic ultrasound, as well as then I actually did another ultrasound while I was ablating something. Clearly, if you don't need ultrasound, you shouldn't use ultrasound. I'm not saying just open it and slap it on for 30 seconds. But if you're doing anything in the upper gastrointestinal, whether it's benign or malignant, I can guarantee you there's a clear reason to use ultrasound some way. Whether it's helping with a partial gastrectomy for a GIST, whether it's evaluating a enucleation for a liver cyst, whether you're trying to identify whether you resect a hemangioma. There are multiple benign lesions that I can give you reasons why ultrasound is going to help you in your diagnostic accuracy and your surgical quality.